You did survive the unit on treatment, correct? Good. And you are pediatrics, obgyn, dentistry, microbiology, neurology. So you had your moment this morning.
Yes, I did.
Good. Family medicine, couple of internal medicine, yes. Nuclear medicine, and family medicine again. Okay. Very good. Anything that was left over from the morning, both the two plenaries and the workshop, anything that is left for discussion? Good. How did you handle the tutorial? Are you self-organized, you work on your own and I just help when needed, or what? Have you identified I'm just chasing you because the most is if you do it. If this is another lecture where I speak and you listen, you will retain very likely little. If instead, I mean, one option is we have an assignment, we have a checklist. One way is to go around the table, one question each, and you'll get to answer that question. That's not very democratic. You go around the table. The other one is that, in school, I don't know how schooling here is here in Kuwait, but we were volunteering each other because it was better to have a volunteer than to have the teacher calling someone. So every morning there was someone that was volunteered. So you can volunteer each other, or you can try to have me speaking, but that's not good for me, not good for you. Now, so harm. How do you imagine a study about harm? What is harm?
Undesirable effect.
Undesirable effect. So, in this definition, harm is connected to what?
Not getting what you want.
To not getting what you want with an intervention.
Yes.
So that's a concept of harm as iatrogenic harm, harm that we may cause by providing intervention. There is some harm that is unavoidable. Every treatment has some downside or some price to pay, but that's an aspect. How would you study that kind of harm? The harm that is associated to treatment. What do you think would be the ideal study design for it?
Just the outcome.
Why a case control?
To see whether the group with the treatment gets the undesirable effect.
Okay, so it may be true. You have to. It's very interesting what you are saying. So, can you think of a classification of harm from treatment? If I make you an example to save time, there was a new anticoagulant that was studied a few years back called zimelagatran. Was the first one in the NOACs, DOACs group. Was a direct thrombin inhibitor. There were mostly two side effects that were discovered during study of this molecule. One was bleeding, was an anticoagulant used to prevent stroke, was causing bleeding. And the other side effect was liver failure, acute liver failure for hepatitis. Are these the same? How would you define these two side effects? Bleeding for an anticoagulant and liver failure.
I didn't understand the question.
Can you name an anticoagulant not causing bleeding as a side effect?
Bleeding is related to the...
Right. So bleeding is related to the mechanism of action. It cannot be avoided, can be minimized, but is sort of expected, measurable, pretty common. Even if you say is 1 in 300, still the number of stroke you save can be 1 in 100. So it happens with a frequency that is somehow comparable to the one of the intended effect, is linked to that by a mechanism, is expected, is unavoidable. Can you name other anticoagulants not causing fatal liver injury? Well, most of them. Most of them. Heparin. How many patients have you killed with heparin because of acute liver failure? Warfarin. No. So what's this second class of side effect was this expected? No, it was not. Actually caused the stop of development of the drug. Was related, was not related. Was rare, was extremely rare. So why I'm making all of this? Because you were saying case control. How can you imagine to study the liver side effect of any medication if that's non-intentional, rare, and not? You have to do a case control. You take the cases. Say now there is this concept that biologicals for rheumatoid arthritis may cause cancer. How you study that? Well, you take cases of cancer among those treated with, and you compare with matched controls not treated with biologicals having cancer or treating with biologicals not having cancer, right? So case control is correct, but for instead the bleeding side effect of, and would you use a case control? No, what would you use?
Can you use the retrospective cohort studies?
Why not? Why? Oh, sorry, a retrospective core study.
Because if the outcomes of the exposure already happened, I'm just collecting the data.
But if the event is expected, is measurable,
No, I'm not
why?
talking about the expected, the unexpected.
Oh, the unexpected. The unexpected, you may do a case control or you may do a retrospective cohort. What's the difference? What's the main difference?
For the retrospective cohorts, the outcomes and the exposures already happened documentally.
Yeah, even in the case control, they happen already.
I think the strength of association or the strength of exposure may be more documented in the retrospective cohort. We can't trace it. I mean,
Case control with the outcome. They start with the outcome.
Maybe the temporal.
Yes, so case control, they start with the outcome and they go back to check for the exposure. Retrospective cohort, they do the same, they don't tell you, they say that they went back, defined the cohort and followed it up prospectively, but indeed they start from the end and they go back anyways, because after math you can only go retrospective. There's a huge difference. What do you think is cheaper? Case control is hugely cheaper, because if you have 4 cases and you have 40,000 exposures, in your case you study 40,004 cases, in her case you stood 8. Or if you really want to be, you have a lot of money, you would study 4 control per each case. So you would have 4 cases, 16 controls, 20 case control. You would study 40,004. Which is much more expensive. In terms of strength, statistical power, beyond 4 controls, you don't gain anything. So when you have 1 case, 4 control, you got already all the statistical power. When it's easier to do the retrospective cohort, when you are investigating, to do a case control, you have to suspect that that's a case. And then you identify the controls. If instead you say, let me check if there's anything associated with, then you take a cohort of patients exposed to whatever drug you want, and you go for cluster of events. You do a different kind of analysis, starting from a database, which is a retrospective cohort study, and you look for association with many events. But if you know the event, the case control is cheaper, faster, and gives you the same level of association. Then, what you get out of a case control, an odds ratio, the difference in risk. If you want to know the prevalence, how often those 4 cases happen, then you need the retrospective. So it's cheaper, it's faster, it's quicker, doesn't give you the information about how often that happen. Because to know how often that happen, you need your design. So they cover slightly different aspects. But for the common, expected, measurable, what would you use? A randomized trial. Exactly like in a randomized trial, you have beneficial outcome and adverse outcome. And harm can be an adverse outcome that you study in a randomized trial when you can, when it's known, expected, common, measurable. If not, you go to cohort study. Are there other kind of harms not related to treatment that you can think of?
Environmental exposure.
Environmental exposure. So asbestos, someone suggested this morning, or smoke, passive smoke, living close by to a electrical line, a nuclear reactor, or I don't know what you have dangerous around here. I have no idea. Close by to Iraq, that might be. I don't know. Is there any Iraqi here? Is there any other country you have border with? No. Saudi Arabia. Okay, so maybe Saudi Arabia. Okay. Yeah, you may. It's more dangerous here or there. Okay. So environmental exposures. Anything else? Can you think of another broad classification of harmful thing? This morning you saw that stroke was more common in Chinese than Caucasian. What's that? Ethnic. Can ethnic be harm?
If it's disposing to certain diseases rather than others.
Do we call that harm?
No.
Risk factor.
Risk factor, okay. So there's no clear-cut distinction between harm and risk factor. Personally, I call harm only what she called harm. So I was very pleased to hear her saying that harm is an unwanted effect of treatment. I call all the rest risk factor, etiology, or prognosis. If you are born Chinese, or you are born Caucasian, or you are born, I don't know, South Americans, it's fine. That's a prognostic factor, that's a risk factor, but you can't play with it. While with treatment, you cannot give treatment or do something. And that's the other main category. Risk factor can be removable or not. Harm is measurable, but it may not be removed, or you may know about it, and then you take it into account. Okay. Now, how do we go? You have read. So let's say you of course you have read the article. Do you need 5 or 10 minutes to go back to the article and refresh it or not? You are welcome to say yes if you want.
Yes.
So why don't you take, because that makes it much easier later on. Takes 10 minutes and read the article. Suggestion. You read the abstract, of course, always. Then you skip to the method. In the method, don't waste time on the sample size or the statistical analysis. Read the patient inclusion-exclusion criteria and read the outcome definition and measurement, because we will be working mostly on that. Patient definition and outcome. Okay? 10 minutes. We'll continue together from now on. Which study design? Which kind of study? Cohort. Prospective or retrospective? Prospective. Does it matter for a cohort being prospective or retrospective? Yes. Main reason being recall bias, sure, and completeness of data. Usually prospective, you decide which data you collect and you get them. Retrospectively, you get what's available. But the main is recall bias, yes. So is a control cohort or not? Yes. So we'll have a group of cases and a group of controls, or if you prefer, exposed and non-exposed. Who defines for me the exposed?
Passengers with the more than 8 hours flight.
More than 8-hour flight. Enrolled when? How these were captured?
By advertisement.
Yeah, but what the advertisement was. You are eligible for the study if you? If you? Plan two. So the enrollment was before? Okay. So subject intending to have a flight equal or longer than 8 hours. When? In the rest of their life, in a month, in 3 months?
3 months.
In 3 months. Okay, so intention in 3 months. How about the control?
Non-travelers.
Non-travelers. So captured how? Same way, advertising. You are eligible if you plan to make a long-haul flight in the next 3 months, or if you don't. Okay, but you like to be a control. Okay, so was randomized? No, they were not gifting long-haul flight. You go there and come back just for the study. No, they were selecting people going or not going, and you ended here or here. Okay. Any age?
Over 18?
Over 18? Any exclusion criteria? Several.
Compression.
Not on anticoagulant. And to be older than 18 and life expectancy more than 3 months. And that's what I
Not
remember.
wearing elastic or
Not using compression stockings?
Yeah.
Can anyone add others? Okay. Are you happy when you see so many exclusion criteria? Depends. So you are not happy. Why you are not happy? Sorry?
They're limiting it too much.
Limit. What does it limit? You're right, but what does it limit?
Passengers now will wear compression stockings.
Right. So it limits the applicability to real people on one side. On the other side,
Answer the question, because we are asking whether the flight is causing the thrombosis or not.
On the other side, it tries to control the variables as much as
right, try to come up with an homogeneous group. So it's good to answer the question, it's not so good for application later on. Yeah, so you're both right. Good. So we have a set of exclusion criteria. Were the exclusion criteria applied also to the controls?
How the exclusion criteria.
So a cancer patient could be a control. Oh, applies for all of them. Okay. Okay, good. If not, we were.
You must have a life expectancy more than 3 months.
Yes, yes. But so the criteria were the same here and here. Okay. Before we move on, how they define the outcome of interest? What's the outcome of interest?
The outcome either DVT or PE.
the primary was, I
isolated calf muscle venous thrombosis. That was the
Isolated calf muscle venous thrombosis. Is that a disease?
ultrasound. No, ultrasound was the diagnosis of it.
Okay, so where the radiologists in the room here? You don't have a radiologist.
Nuclear medicine, not radiologist.
Okay, we can do a VQ scan, but that's it. So why they use a symptomatic isolated calf clot seen at ultrasound?
More objective.
More objective. Well, fatal PE is more objective.
Cheap and non-obesity.
Yes? So that's not the reason.
What's the question? Why did
The question is why they use that thing that I can't even say that she said so well. That a isolated, objective calf.
DVT.
Why?
why
Because
this
they can
was
choose
there?
which muscles they can study. They chose the gastrocnemius and soleus solely. But these are two muscles they wanted to look at.
Why? I mean,
Maybe related to the long flight and the position of the passenger there?
No, it will be, and maybe the assessment or the clinical diagnosis based on suspicion only is not accurate. It should be
well, I mean, a compression ultrasound that tells you that you have a clot in the femoral vein is not objective, is more objective. You can do it.
By clinical science only. It can be another differential.
No. I'm saying ultrasound diagnosis of a femoral clot is more objective than diagnosis of a clot in the calf. Because here you have a vein that big and you press it. If it disappears, means that there is no clot in. If you can't compress it, there's a clot. In the vein of the calf, it's very, very small. You can make it disappear just because it's small. You have to use the Doppler. It's much more subjective. So it's not precision. Why you think they pick those? They tell somewhere in the paper.
It depends on the background. Like, for example, they knew that the most common site of
It's like, let's say, we are studying diabetes, and I use as outcome in my study HbA1c level instead that progression to diabetic nephropathy or cases of foot amputation for diabetes or episodes of ketoacidotic coma. Why I may want to study
Available and cheap.
available and cheap. So how do I call, say, hypertension? Why do we treat high blood pressure? Why we reduce high blood pressure?
To prevent.
To prevent,
or
like, which kind of complication we want to prevent? Cardiovascular, for example, MI, or stroke, or kidney disease, dialysis. Because kidney disease, a bit of impaired, decreased glomerular filtration rate, provided it's still acceptable. So we are interested in hard outcome. We want to prevent stroke. But how we study blood pressure medication, effect on blood pressure, how we call the effect on blood pressure, we call the hard outcome, stroke, myocardial infarction, we call it hard. How we call the other outcome? The effect on blood pressure, the effect on glucose for antidiabetics, surrogate outcome, or intermediate outcome. They are much easier to study, but they are good only if they are predicting the hard outcome. So they choose that idiopathic, isolated, blah, 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 assuming it's more common, and assuming when you have it, if you don't treat it, that will grow up, become a femoral vein clot, which is easier to measure and diagnose, but very likely only 1 in 20 gets up here, and then from here it breaks, go up to the lung, and 1 in 1,000 kills you. So ideally, you need to diagnose 1,000 of those to get 1 PE. And so they said, well, let's study what's easier, more common. as a surrogate outcome. Okay? Anything else on outcomes? How did they assess the outcome? Ultrasound. But ultrasound done when?
Within 1 week.
Within 1 week. Twice. Wow. Baseline. What does it mean, baseline? Before travel.
You shouldn't have any DVT before even, or
Why?
excluded.
Why?
Because you will not tell if this is the flight attributable or
Right, because to measure if there is a risk associated with something, you need not to have the thing already, right? Okay, so they did ultrasound before, and did they find anyone who had that thing before?
yeah.
Did they find any case where there was this kind of clot in the calf before? At the baseline? Did they find any at baseline?
Yes. For
4? Okay, so they found 4 here. And how many in the control? I think 1 or 2. I think 2. So 1 or 2 in the control. Let's say 1. So now these were happy people planning to go on vacation. They get an ultrasound before going, and 4 of them had this kind of clot. 1 of the control had the same clot. So it's a good outcome. It's an outcome that normal people doing well, walking out of a travel agent has that thing. No, well, so what I'm saying is, if there were none having this clot before, one might say, oh, no one in normal condition has this event. So you have to have a flight to cause the event. But if you have the event before, aren't you worried that we are measuring something that may have no relationship with the travel? Okay, what will make you sure? Because you have 4 here and 1 there. So my observation is it's not really a disease, because do we know what happened to those people? In the study, they gave them 10 days of heparin. But if you think that they measured 2,000 people and they found 5, how many of these things will be around? Here we are 100 people, there may be no one. But if you take Kuwait City today, how many people are in Kuwait City? I don't know, how many inhabitants are here? 4 million. So there will be about 200 of these today in Kuwait City. Are they going to emerge? No. Are they doing anything? No, they don't know they have it, they just have it. Maybe a few of them over the next few days will develop a clot and will go to emerge. Many others, they will likely do nothing. So this may not be an important event. Okay, how many had these after? How many, so this the baseline 4. How many after the trip had this thing? No, okay, these 4 were excluded. All the others, they had their flight. How many they measured after? 27? So 20 here and 7 here. Okay. No?
27 in the passengers.
Oh, 27 here. 12 in the control. Okay. So, first of all, why is this? Why in the control, Why I have 1 before and 12 after? Is a control group. Why you have a difference? Why you have 1 before and 12 after? Would you expect, or you would have expected 1 before and 1 after, or 6 before and 6 after? What do you think? Why you see an increase in a control group?
Maybe confounder.
Yeah, there's some confounding. Maybe the radiologist here was saying, this stupid study, they send me normal people, do scan, they baseline, why they should have anything. And then after, they were blinded. The ultrasound person was not aware if that person had a flight or not. So maybe they were more careful and they picked more. But I don't see any reason why you should have a difference here.
The control group also has a higher incidence of previous TB.
Yeah. So good reasoning. But here, I would expect that it depends on the examiner. So here is the radiologist that is different. Here, okay, why here there are more than here? Why is this difference? The radiologist, why should he find more there? They still have to go to do the flight. So what can explain this difference?
Blindness?
Not sure. No, not blinding. Maybe different population?
Yeah, it just happened that the people were.
Maybe that if you plan to do a flight and you know that there is a study about clot and you are worried about the clot, you are more likely to be enrolled in the study, while instead if you are normal and you just like research and like to contribute to research, you enroll here independently if you have risk factor. What I mean is, if you know that you have risk factor, someone in the family had a clot, you had a clot in the past, you know you have a thrombophilia, here you say, oh, well, good to be in a study. If it happened to me to have a clot, they will discover it. So you may select a high-risk population here. Why here, very likely, you select a healthy population and say, oh, no, I'm very well, I'm poor, I'm not traveling, but I'm healthy. If you need a control, I'm the right one. While the one knowing that he had a clot, he might say, I had a clot already on my own, I'm not. So here, the difference is likely explained by the population. While here, the difference is more likely explained by bias in the observation. Now, what about dropouts or withdrawals? The number of those not presenting for the second observation was the same in the two groups or was different? Lost at follow-up. I'm sure is reported. Yes, those excluded.
170 of the passengers.
How many?
117 for different reasons.
Okay. How many didn't show up?
22 were unwilling to undergo examination.
Okay. And then?
87 used compression stocking or heparin.
87 use compression stocking, and then? Or heparin?
4 were
Treated with anticoagulant.
Okay. In the control instead?
4 was ICMVT or DVT.
But how many in the control? 117 in the 70. And how many did not undergo the evaluation?
9 were unwilling to undergo.
9. And how many wore compression stockings?
7 were treated with anticoagulation.
7.
With anticoagulation.
Okay.
And one showed isolated calf muscle.
Okay. And so these were 17, 17, non 70.
1 7.
17. Okay. So you see, the population is clearly different, not only because of the rate, but even for this one. Many more here were non-analyzed because they wore compression stockings or didn't show up for the examination. While here, almost everyone was analyzed, only 17 were not, 9 did not show up, and 7 did some form of treatment. So the two populations are different somehow. Possibly this one here is at high rate of clots. They excluded these 4, they excluded this one, and then they conclude that here there are more events than here, so this one, the flight, increases the risk. And maybe, but if you look at this one, and if you consider that you had a 12-time increase here, actually this is less than 12-time increase. So you may even say that this protect. If you were considering the baseline risk, here it went from 1 to 12. Here it went only from 4 to 27. So maybe it was not really that strong. They don't consider at all this difference here. They just say, oh, those with a clot we didn't consider. Anyways, and this difference here is really difficult to explain. To me, it means that either there was 1 and these are all false, or they missed 12 here. And it also means that this 27, if they saw many more here than here, might be much lower. So not sure. Anyways, so this is the description of the study. Now we have analyzed the population and we have analyzed the outcome. Now we'll go and we answer the question. This step of appraisal is the minimum that you have to do. Even if you use pre-appraised evidence, even if you use the one we select at McMaster, or if you read up to date or whatever, you can trust that others went into, did they do the study right? Did they measure the outcome right? So all of these can be somehow done by others for you. But deciding if your patient fits in this population is you. To know if you can apply this evidence to your patient, the easiest way is to check if your patient would have been enrolled in the study. The patient you have in the clinic, was the patient would have been included or excluded? If you end in saying excluded, well, these results do not apply to your patient. And then the outcome. If you have a patient in clinic that tells you, I'm going for a flight such and such, do I need to do something? What's my risk of having a clot? What would be your answer based on this study? What's the risk for someone traveling over 8 hours to have a clot? How many of these 27 clots were symptomatic clot? How many of these 27 had a painful leg? Because when the patient asks you if he can have a clot, you mean a clot that can, can cause some problem to his or her health. So a clot that causes pain or can grow and give a pulmonary embolism. How many PE did they observe in the study? PE, I think none. If I recall correctly, they didn't see any PE. I mean, they didn't, no one died. Maybe there was a PE, you may be right. No death, 1 PE, how many DVT? 7. And how many were symptomatic? the one idiopathic isolated calf clot? How many had symptoms? Pain in the calf? Two. So what would you tell your patient? What's her or his chance of dying?
Very low.
0. Unless the flight falls, there's no way you die. Okay. Chance of having a PE?
Very low.
Very low. I mean, in the order of 1 in 2,000, right? They enrolled about 2,000 patients. Chance of having a DVT is about 7 in 1,000. So it's less than 1%. Chance of having pain in the calf that can be a small clot there?
0.
Yeah, very low. Okay, so if you use this paper that way, that's the way to go. You look at the symptomatic event and you use it. In our scenario, they are trying to use this paper to decide if this lady can have a clot. I'm not saying it's a stupid way of using the paper, but if you have a patient in eMERGE that tells you that had a long haul flight, how do you do usually the diagnosis of DVT? You use the Wells score? Yeah. Long haul flight is there, get 1 point, period. Then if it's only that one, is not enough. If the patient has other risk factor, that can be 1 extra point, right? So that's the way you use it. You don't need really to look for the evidence. It's in the Wells score already. But if instead you were to make a suggestion about a future flight, you might use it. Now that we have this level of evidence, let's go down the list of questions. Who has the list of questions? So let's go through it. You read all the questions and they answer in order. Let's do you like it? Yes, you like it. Come on. It's quicker. Okay, so good. Question number 1.
So, under the category of did experimental and control groups begin the study with a similar prognosis? You have the first question, which is, did the investigators demonstrate similarities with respect to all known determinants of outcome? Did they adjust for differences in the analysis?
So, your turn to answer. What do you think?
I think they have the same inclusion criteria for both groups, but regarding adjustment to the differences, I don't think
So you are saying they didn't do an adjusted analysis for the difference in the rate. True. Why do you think they didn't do an adjusted analysis? Because they were bad and they didn't have a good statistician, or there's another reason? I'll tell you. You need 10 events per each variable you want to adjust for. So they didn't have enough events. If you have, they had about 10 characteristics, 10 risk factors. If you want to do a multivariable adjusted analysis, you need, as a rule of thumb, 10 events per each predictor. They had a handful of events, so they could adjust for 3 predictors only. At that point, how you choose the 3. And they prefer not to do the adjusted analysis. But your observation is correct. No point in measuring the predictors if you can't adjust for them. Unless, what's the only sort of very raw kind of adjustment you can do? When you have few events. You cannot adjust, but you can look if those patients having event all add at least 1 or maybe 2 risk factors. It's not an adjusted analysis, but if every single one having an event had also a risk factor, you may wonder if what counts is the flight or the risk factor, because they had already a risk factor for the clot. So it's not surprising they have a clot. Patient with the risk factor every once in a while have a clot. and it happened also when you are on a plane. By the way, 4 of them, they had the clot before the plane. So, okay, good. Next. Oh, anyone want to add something? Or we are happy with what Mohammed provided as an answer? I'm happy personally. Good. Next question.
Okay, for case control studies, were exposed patients equally likely to be identified in the 2 groups?
Yes. Does this question really apply to this study? It's not a case control study. Right, so it's not yes, it's yes, of course, because it's a prospective cohort, but doesn't really apply. Yeah, good. Following question.
Okay, the second category.
Yeah.
Did experimental and control groups retain a similar prognosis after the study started? The first question is, were the outcomes and exposures measured in the same way in the groups being compared?
The ultrasound and
Because they did have, both had base ultrasounds.
Yeah.
Yeah, and afterwards.
So they started equal and they continued equal. Yes. Good. Next.
Was the follow-up sufficiently complete?
How long was the follow-up? We didn't touch on that.
4 weeks.
4 weeks. Is that enough? Is that enough? No.
Some people, after long flight, they still have inspections even 1 year after the flight. 3 months, 6 months, and 1 year.
So you may be right. So this 1 year might have had a flight 4 years back. It's possible. How can you decide if it takes a month, 4 months, or 8 months for something that starts there to get to be clinically evident? Say you are a surgeon, no, you are an internist. But is there any surgeon here? No, well, so you are not a surgeon, but sort of, well, no, your obstetric side, no, but your gynecology side is surgical, right? So if someone comes back with an infection 2 months after surgery, you tend to consider that as a complication of your surgery? No. Again, depends which kind of infection is, because if it's an infection, is an abscess where you operated, you may say, oh, too late, like the warranty of the watch. No. Warrant's over. Well, it's over, but how can I have an abscess there if not? Yeah, right. But if the abscess is in the ear, and you usually don't do ear surgery, right? Why should be there? Endocarditis after surgery is a slowly developing disease. So you may say for endocarditis maybe 3 months. For an abscess in the pelvic area can be forever, because one may say, oh, I got recurrent infection after surgery, I didn't have those before, I had them always after, and now the abscess is 4 years after, and try to claim to make suitor for being responsible for that. So depends. For this specific case, is 4 weeks acceptable? Do you know the definition of provoked and unprovoked VTE? For how long you consider a VTE provoked after orthopedic surgery? 6 weeks, I think, is the puerperium. So after delivery, you count 6 weeks. After surgery, you count 1 month. But 1 month for what? For a symptomatic DVT. For a DVT like this, I don't know. It may take ages. to go from there up to here and then break and become symptomatic. So I don't know if I'm happy with 4 weeks. But it's a matter of biology and what's reasonable. But whatever you consider as a follow-up is what you would tend to consider as a reasonable time distance between the event and the effect. Okay, so, but in terms of completeness, does the question refer to the length or to the number of patients that were available for analysis? Number of patients. So they missed about 10% here and about 1%, no, yeah, 1% here, correct? So 10%. Is 10% lost acceptable? Yes? No? Any idea? Is always the same or depend on the study? Depend on the study. So, and particularly depends on what? Sample size. Why you say sample size? Because if you study 1,000 and you lose 100, or you study 10,000 and you lose 1,000, it's still 10%. What's the problem? No, it affects study power, but it affects study power if you lose 1,000 in 10,000 or 100 in 1,000, affect the same way. What is critical is how many you lose as compared to how many events. So what's the event rate here? The event rate here is about 3%? No. 27 in 1,000? What's the event rate? In the treated group, in the flying group, what's the event rate? What's the, I have it somewhere, but the incidence of asymptomatic isolated is 2.8%. So if you have a 3% event rate, can you accept losing 10% of patient? No. Because that 10% of patient is 3 times higher than your event rate. If those 10% were all dead of PE, you would screw up the study. You would say, oh, the incidence is 3%, and you have a pile of dead bodies that were all dead by VTE. So if instead was the opposite, the event rate was 10%, and you had lost 2%, well, that's acceptable, even if those, I mean, it's always bad to lose people, but even if those 2% were all dead, your rate would go from 10 to 12. It's a minimum change. While in your case, would go from 3 to 13%, which is a huge change. So you have to judge the number of lost at follow-up in comparison to the event rate. So in this case, was the follow-up complete? No. What did they say? They say 100%. Oh, sorry, we were considering not the follow-up. These are not lost at follow-up. These are patients that were screened and not enrolled. Excluded, but excluded before. They say that those entering the study, everyone was accounted for in the end. Even if these 22 that didn't accept to come back for the analysis, seems to me that they were studied first and didn't come back. So I would say that follow-up is not 100% as they say there. No further, whatever, a week after the second, no that. Okay, but anyways, doesn't really matter how is in this study. But the concept is you don't want more patient lost than add events. Next.
What are the results? How strong is the association between exposure and outcome?
How strong is? Yeah? How much is that? 2.8. 2.8, yes, for any thrombotic event. For DVT, 4.4. Okay. Absolute numbers. Is on the screen. 0.7 DVT in those flying, 0.2 in controls. Okay. Next.
How precise is the estimate of risk?
How precise is the estimate?
Confidence interval,
Yes?
1.46 to 5.4 for the risk ratio of 200.
Okay. So, are you happy with any event 1.5 to 5.5? Is that large or narrow? Large. Why you say large? How you judge large or narrow?
We will take the two extremes and
Yes.
interpret according to the best number to be less.
Okay.
The lower end would be only 1.4, the rest will be, but on the other hand, it would be 5.5 or
Okay, so let's say is 2.8, right? The midpoint, 1.5, 5.5. Which use you do of this risk? Let's say you decide to do what? Not fly. Would you make a different decision of not flying if you knew your risk is 1.5 as compared to 5.5? Would that change your decision? Not to take a flight. You have won a lottery, you have a free flight for Patagonia, full cruise paid is about $20,000. Do you go or not? At 1.5 you go? At 5.5 you go? Right, so that's precise enough for you. Good. Maybe if it was 15? 15.5?
I'll think about it while I go.
Okay. Maybe taking a shot of heparin. So what's the risk of taking one single shot of heparin to cover for a flight? Almost nothing. So would you take it's just painful, but would you consider that it make a difference? 1.5 or 5.5? Very likely no. So this seems precise enough. This one here, I'm a bit more worried because this is so close to 1 that it can really be non-significant. Now, even significance in this field, I don't care a lot. Here is can be no effect or can be as high as 20%. So this is for sure very large to me because this is say there might not be risk or the risk can be 1 in 5. I'm not happy with this. But this one here, to me, it's okay. Is a subjective judgment. For her, she would go on the cruise no matter what. So she would not even ask her doctor about what the risk is. Yeah. Good. Next.
How can I apply the results to patients' care? Were the study patients similar to my patient?
What do you mean? What do you think?
So the 60 whatever patient, right? The 64-year-old female patient.
Yeah.
Oh, okay. So, similar.
The patient was, I think,
Non-smoker, female, 64-year-old, emergency, getting a chest pain. There was a chest pain.
mild lower extremity pain, transient chest pain, 3 weeks after. Sorry?
If lower flew back from Spain.
Yeah.
So 8 hours.
So 3 weeks before she flew, she had this mild lower extremity pain, and now 3 weeks after, she has chest pain. No smoker. And then her doctor is not really kind to her and says that she's always hustling about disease that might have, might not. You are very happy when you are in emerge and you call the doctor and you get this kind of feedback. That helps you a lot. Yeah. Okay. So, does this study apply to this patient? It's a judgment. There's no right or wrong.
I think there is a similarity. She does not, yeah,
Demographically, it is. Clinically, it isn't.
So, maybe the patient in the study, they had slightly more risk factor. But not everyone in the study had risk factor. So this patient could have been in the study.
She can be. She's
Yeah.
not excluded.
So this is what we are given by this is what we have decided together for the course. I was not really happy with this slide because I think that you can't tell if this patient is higher or lower risk than the patient enrolled in the study. In the end, she likely has no clot, but 97% of the population of the study had no clot. So she might well be in the study. The only thing is that she flew back from Spain while the average length here was 12-15 hours, but still.
Was the duration of follow-up adequate?
For this question, can I apply the result? When so are you okay with duration or not? Yeah, because you are seeing a patient 3 weeks after, the study covers, yeah. So that's okay. Next.
Should I consider my patient to be at risk for VT?
Why yes?
Well, she traveled for 8 hours or more. And she's presenting with symptoms. And I have some evidence, but I'm not sure. Yeah, I have evidence even for this study, right?
No. You can conclude as you want. You have to tell me if you consider her at risk for this study or for something else.
Yeah, for such patients, yes. If they present to me with those symptoms and they have trouble, there was a history of risk.
So let me change the scenario. This patient is exactly as it is in this scenario, but she didn't go to Spain. Would you send her for an ultrasound or a D-dimer? She comes to you saying, 3 weeks ago I had mild leg pain, now I have chest pain. What would you do with this patient?
How many hours did that?
No. Let's assume that the patient is in the control group.
Okay.
Is in the control group. She had she's a non-smoker, 64, blah, blah, blah.
Apply the word score, set the probability, and if she's high probability, we'll do it anyway. If she's low probability or just X-ray whatsoever, send her a VQ scan, but then we will decide.
Yeah, how you think she would do on the well score? Low. Yeah, it's very low. So what would you do in the low score?
D-dimer.
D-dimer. If the dimer is negative, via Condios. If instead,
Positive ultrasound.
yeah. And would you do differently because she had the travel? Would you skip the D-dimer? No. The well score would be 1 instead of 0. Okay. Anyway, low. So this is your answer is this patient has a low well score. She's not at risk, period. Doesn't matter what the study says. Let's see what they answer. Well, they don't really answer. But this patient is not at high risk. Of course, she can have a DVT, everyone can have a DVT, but this would be very unlikely. Okay, next. Oh, that's it, good. Yeah, so in applying these numbers or these data to your patient, would you be worried by everyone having had ultrasound? What do you think that will impact? What's the impact of everyone in the study having done an ultrasound?
Before the study or after the study?
Both, but mostly after. They found many more events than you would have in clinical practice. And they say, oh, but you know, we found this small clot and then they grow, and we don't know if that happened. There is very little evidence that says that, because which kind of study, that would be an etiology study. You find this small clot, you do nothing, you don't give treatment, you call back the patient every 3 days, continue to do the ultrasound and see what happened. And they might disappear. We might have this clot all the time, and then they just disappear. On the other hand, if you have to do a study where you wait for people to fall dead when they stand up after the flight, it takes ages. Okay, any final question? If not, you have gained 5 minutes of stretching. 10 minutes of stretching, wow, that's amazing. Please note it on your evaluation. Oh, fill the evaluation, please. You have no excuse. We were not late, so you have to do it. Good. Thank you.